Hello, my name is Brian Budgell, and I would like to welcome you to this presentation on the subluxation event. Previously, we had seen that there are three different but highly prevalent meanings for the word subluxation in the chiropractic literature. Today, we want to talk about the subluxation event as an instantaneous biomechanical injury to the vertebral column. In fact, when you speak with chiropractic patients, you see that it is often the case that they can clearly remember the moment in time when they began to suffer from back pain or neck pain. It may have been during what should have been some harmless movement. It may have been when they were straining to lift something heavy, or it may even have been the result of a traumatic injury, such as a motor vehicle accident. But the point is that the onset is often at a very specific moment in time. And in this presentation, we want to talk about the biomechanical phenomena that are going on during that specific subluxation event. We will cite two experimental studies modeling the subluxation event. The study by Dr. Koji Kaneoka presents a model of a whiplash injury, while the study by Dr. Cholowicki involves an instantaneous injury to the lumbar spine. The study by Dr. Kaneoka was quite interesting. Here's a photograph of the experimental setup, taken from his paper. He had seated subjects roll backwards down a ramp and collide with a barrier so that they experienced a low-speed whiplash injury of the neck. He recorded the motion during whiplash via cineradiography and compared this with normal active movement of the neck. The rapid acceleration of the whiplash event means that the normal stabilizing elements of the neck could not have had time to come into play. The subjects were not controlling their neck movements, rather the movements were driven by external forces. In normal cervical extension, when the subject is controlling movement, the C5 vertebra rotates backwards around an instantaneous axis of rotation, abbreviated IAR, within the C6 vertebral body. This allows the adjacent surfaces of the facet joints to slide smoothly across one another. However, during Kaneoka's model whiplash injury, the axis of rotation was shifted upwards into the body of the C5 vertebra. Why is this important? Because this causes the adjacent surfaces of the facet joints to jam together. Thus, without the normal stabilizing effect of the cervical muscles, abnormal motion causes injury to the facet joints. This is borne out by a number of studies showing that anesthesia, or denervation of the facet joints, often relieves the pain of a whiplash injury. The study by Cholowicki also involved cineradiography, but of the lumbar spine, as a subject lifted a heavy weight. Recall that there are three fairly distinct layers of muscle which surround the spine and control posture and movement. The deepest intervertebral muscles run from one vertebra to the immediately adjacent vertebra. They lack the muscle mass and mechanical advantage to have any significant effect on intervertebral movement or posture. Their role is more likely to act as sensors of intervertebral movement, and, as it turns out, these muscles have very high densities of muscle spindles, making them acutely sensitive to vertebral position and movement. The intermediate muscles, such as semispinalis, are larger and have a longer lever arm. They are not biomechanically suited to being prime movers of the spine, but they could have a role in stabilizing vertebra and smoothing out the movement induced by larger muscles. It is the overlying long muscles, such as longissimus and iliocostalis, which have the muscle mass and the long lever arms to produce real forces capable of moving the vertebral column. On the other hand, because of their broad attachments, they are incapable of either producing or detecting fine movements. That must be the responsibility of the deeper muscles. Cholowicki observed with cineradiography that as one subject lifted a heavy weight, he suddenly experienced a sharp pain in his back before catching himself and correcting his motion. Simultaneously, the cineradiography recorded an individual vertebra slipping slightly out of alignment with the rest of the lumbar spine. What was happening in the subject's back? The most superficial back muscles, such as the longissimus and iliocostalis, shown in yellow here, would scarcely be affected. The mid-level muscles, such as semispinalis, had the job of stabilizing intervertebral motion, and it is likely that one of these was unexpectedly overloaded by the weight that the back had to bear. The deepest muscles, shown here in blue, would proportionately be much more affected by the slippage since, as a percentage of their resting length, they would undergo much more distortion, and they have many more muscle spindles to signal that distortion. It therefore seems likely that the mid-level muscles, by virtue of giving way, contributed disproportionately to the subluxation event. This idea of a very localized failure of stabilizing elements of the spine is consistent with what patients and their examining clinicians report, that the source of pain or aberrant motion can often be traced to a very specific level of the spine. It's also consistent with the observation that a spinal manipulation delivered to that specific site often provides rapid and substantial relief. From Kanioka's and Cholowicki's observations in the cervical spine and lumbar spine, we have a robust biomechanical model for the subluxation event. This has been referred to as the spinal buckling model and involves a brief failure of some stabilizing element of the spine. This is more than just a hypothesis, since the motion has been documented on film, and it makes sense both in terms of our understanding of human biology and clinical experience. Thank you very much.